Hi, my name is Joyce Artean and I'm going to tell you about immunotherapy in renal cell carcinoma of chronic hepatitis E virus infections. Definitions: renal cell carcinoma, RCC, formerly known as hypernephroma, is a kidney cancer that originates in the lining of the proximal convoluted tubule, the very small tubes in the kidney that transport GA, glomerular filtrate, from the glomerulus to the descending length of the nephron.
Renal cell carcinoma is the most common type of kidney cancer in adults. It accounts for approximately 3% of adult cancers, and the incidence has risen steadily by about 2 to 4% each year in the past few decades. It is effectively a collection of different types of tumors, each derived from the various parts of the kidney cell and displaying salient genetic characteristics, histological features, and, to some extent, clinical picture. When it metastasizes, it has the tendency to spread to the lymph nodes, lungs, liver, adrenal glands, brain, or bones. While the exact cause of renal cell carcinoma is unknown, there are risk factors that increase the chance of developing it, such as smoking, high blood pressure, family history of kidney cancer, and obesity. The chance of developing renal cell carcinoma increases with the age, and males have double the chance of having it compared to females. In a lot of patients, this cancer may not produce any symptoms for most of its course. Only about 10% of patients present with the classic triad of flank pain, blood in the urine, and lump in the abdomen. Other signs and symptoms may include unexplained weight loss, fever, night sweats, weakness, fatigue, nausea, and high blood pressure. Renal cell carcinoma is associated with a number of paraneoplastic syndromes, which are conditions caused by either the tumor hormones produced by the tumor or by the body's attack on the tumor. In about 20% of these patients, paraneoplastic syndromes are present, such as high blood calcium levels, high red blood cell count, high platelet count, and deposition of amyloid protein in one or more organ systems. To diagnose renal cell carcinoma, signs and symptoms and past medical history play significant roles. Based on the symptoms and signs, a range of biochemical tests are considered to provide sufficient diagnostic clues. Kidney imaging is vital, mainly consisting of ultrasound, CT scanning, and MRI scanning of the kidneys. Biopsy of the suspected kidney mass helps confirmation of the diagnosis. To evaluate the extent of cancer spread, PET scanning is the standard imaging modality. The therapeutic approach to renal cell carcinoma is guided by the stage or degree of tumor spread, pre-existing medical conditions, and overall health and age of the person. The principal treatment options for renal cell carcinoma consist of surgery, immunotherapy, and targeted therapy. Partial or complete removal of the affected kidney is the standard treatment for localized renal cell carcinoma. Immunotherapy, or biologic therapy, works by boosting the body's immune system to help destroy cancer cells. Cytokines are the artificially engineered versions of natural proteins that activate the immune system, and the ones most often to treat kidney cancer are interleukin-2 and interferon alpha. The targeted therapy works by blocking growth of the new blood vessels that nourish cancer cells or downplaying important proteins in cancer cells that help them grow, or both. Clinical response rates with chemotherapy, either monoagent or combination, are usually less than 15%. Renal cell carcinoma is not very sensitive to radiation, and radiation therapy is more often used to palliate or ease cancer symptoms in case of cancer spread. For more information about list of expert doctors, hospitals, and ongoing clinical trials, please visit
Applications in medicine. Immunotherapy is defined as clothing cancer by activating the autoimmune response against the tumor rather than by attacking the tumor directly. Immunotherapy can induce long-lasting anti-cancer response owing to the generation of antigen-specific immune memory, either through memory T cells or antibodies. Several crucial steps are needed to mount an initial effective immune response against tumors.
I had the opportunity to participate at the Ipsen Satellite Symposium in Kidney Cancer, together with my colleagues Dr. Bernard Scudier, Dr. Tom Pauls, and Dr. Tony Chueri. And my task at that Satellite Symposium was to translate the data that we have, the clinical report of the phase 3 trial, the Meteor trial with cabozantinib, and the Checkmate 025 trial with nivolumab, how we can translate that into selecting our treatment for patients in second line after failure to one prior tyrosine kinase inhibitors. At that moment, we presented 3 different clinical cases, and in this clinical case, we showed different profiles of patients who were candidates to one or the other alternatives. Unfortunately, in this field, we don't have a biomarker, a predictive molecular biomarker that really can help us in the daily clinical practice. So we need to base our treatment decisions in things in factors like patient characteristics, age, comorbidity, co-medications, or in tumor characteristics, how bulky is the tumor, what is the tumor burden, how fast the tumor is progressing, and of course, the tolerability and the clinical outcome to the first line the patient receives. So I really hope the attendees, well, at least they thought twice about what they are doing in their practice.
Pros and cons. The advent of immunotherapy has brought about a paradigm shift in the treatment of advanced RCC. Properly integrating immunotherapy into the present treatment is challenging. Preclinical research has demonstrated the role of VEGF is suppressing tumor immune response and attractive strategy to combine with ICIs. The results are encouraging and have led to larger confirmatory phase 3 trials, which are now actively accruing patients.
Checkpoint inhibition, that is actually a form of immunotherapy. So that whole class of therapy, what it essentially does is ramps up your own immune system and releases the brakes that the tumor created to slow down your immune system from fighting your own cancer. It lets go of the brakes so that you can fight the cancer yourself. And when it works, it is actually astounding. It's really quite remarkable. It doesn't work for everybody, but when it works, it's really quite remarkable.
Issue applied in Ecuador. Renal cell carcinoma is a rare urological cancer, representing 3% of a cancer in women and 5% in men, with an incidence of around 400,000 cases worldwide. The prognosis is poor. 30% of patients are metastatic at diagnosis, and almost 30% of the remaining patients will develop metastasis detected during the follow-up. Conclusions. Renal cell carcinoma is a rare type of urologic cancer and has a poor prognosis, with 30% of metastatic patients are diagnosed. The angiogenesis and target immunotherapies led to treatment remodeling, emphasizing the role of the tumor microenvironment. New strategies are emerging to improve the efficacy, and emerging drugs and under evaluations in ongoing trials. With the different treatments options, there is an urgent need in identified biomarkers in order to predict the efficacy of drugs and to better stratify patients. Chronic hepatitis E virus infections. Definitions. Hepatitis E is a liver disease caused by the hepatitis E virus, HEV. The virus has at least 4 different types, genotypes 1, 2, 3, and 4. Genotypes 1 and 2 have been found only in humans. Genotypes 3 and 4 circulate in several animals, including pigs, wild boars, and deer, without causing any disease and causing early infect in humans. The virus injects the soul of infected person and enters the human body through the intestine. It is transmitted mainly through contaminated drinking water.
So now let's meet some patients so we can put to work what we have learned about hepatitis E diagnostics. Our first patient is Hannah. She feels sick and had to vomit at home. She's feverish and her skin has a yellowish color. Her symptoms started 1 week ago. 4 weeks ago, she came back from Mexico when she visited family. Obviously, we think about hepatitis. Let's order lab tests. In Hannah's lab report, we can see that her liver enzyme function is significantly elevated. Furthermore, her hepatitis E tests are positive. Hepatitis E RNA is also detectable. So what's your diagnosis? Hannah has no history of immunosuppression. So let's take a look back at the graphic dealing with immunocompetent patients. Her ALT is very high, which signifies serious liver damage. Anti-HEV IgM and IgG are both positive, and we could detect RNA in Hannah's stool. Based on these results, we can conclude that Hannah is most likely in the early phase after infection. So Hannah is suffering from an acute hepatitis E infection. Let's see our next patient. Our second patient is Pete. He suffers from abdominal pain of recent onset. In the lab report, we can already see elevated liver enzymes. Pete received a lung transplant 8 years ago. Currently, he is on immunosuppressive therapy. Furthermore, he tells us that he's a passionate hunter. Based on Pete's history, we include hepatitis E screening in our lab report. We can see that his liver enzyme function is significantly elevated. His anti-HEV antibodies are negative. However, the lab detected HEV RNA in Pete's stool. What does that mean? Since we know that Pete is taking immunosuppressive medication, we should consider this in interpreting his lab results. We know that immunocompromised patients can have problems producing antibodies to the virus. So in Pete's case, it is essential to measure RNA. His lab report shows elevated ALT levels as a sign of liver damage, but negative antibody tests. However, there is RNA detectable in his stool. Pete is suffering from an active, ongoing HEV infection. Based on the laboratory findings, we cannot determine when Pete was infected. It may have been recently or more than 6 months ago. However, it is not important to know that. What is important is that Pete gets appropriate treatment and follow-ups. Congratulations! Now you can handle hepatitis E lab results.
So I hope you liked this video. Absolutely make sure
Applications in medicine. The hepatitis E virus is transmitted mainly through the fecal-oral route due to fecal contamination of drinking water. This route accounts for a very large proportion of clinical cases with disease. The risk factors for hepatitis E are related to poor sanitation, allowing virus excrete in the faces of infected people to reach drinking water supplies.
Hepatitis E is RNA virus. Spread by the fecal-oral route. Incubation period 3 to 8 weeks. Common in Central and Southeast Asia, North and West Africa, and in Mexico. Causes a similar disease to hepatitis A, but carries a significant mortality, about 20% during pregnancy. In general, hepatitis E is a self-limiting viral infection followed by recovery. Prolonged viremia or fecal shedding are unusual. In acute infection, IgM antibodies to hepatitis E virus are positive. Does not usually cause chronic disease. A vaccine is currently in development, but is not yet in widespread use. Thank you for watching.
Pros and cons. Pros. At the end of therapy with ribavirin, HEB clearance was observed in 95% of the patients. Cons. A recurrence of HEB replication occurred in 10 patients after ribavirin was stopped. A sustained virologic response was also observed in 4 patients who had a recur and were retried for a longer period. Anemia was the main identified side effect. Issue applied in Ecuador. Hepatitis is not an endemic disease in Ecuador. It is present in less than 8% of the populations. Nonetheless, there are an estimated of 20 million HEB infections worldwide every year.
Dennis Lyon's skin cancer had mutated nearly a dozen times by the time he came to the Cancer Center at the University of California at San Diego.
When I came to UCSD, I had been to other major cancer centers in the country because I have a very rare cancer called basal cell carcinoma metastatic. And most of them did not have a lot to offer me in the way of treatments.
2 months later, he was in complete remission.
In my case, we haven't had new tumors in months and months. And everything that I have had has shrunk to the point of being non-existent in some cases.
Lyon is one of the lucky few that have kicked cancer by taking drugs called checkpoint inhibitors that use the body's immune system to fight cancer.
The basic thread that runs throughout the different approaches in immunotherapy is the idea of reactivating a patient's own immune system to fight their cancer.
Checkpoint inhibitors unmask cancer cells that can hide from disease-fighting antibodies, called T cells.
The tumor has found a way to shut off the immune system. And checkpoint inhibitors prevent that from happening.
When the T cells can see the cancer cell, they can attack it, but it does not work for everyone.
Over the past 6-7 years, we've started to see these drugs actually come into clinical practice and make a real difference in the lives of some patients. And I'm going to underline the word some patients because it's still not enough patients. Unfortunately, the minority of patients respond to immunotherapy.
The drugs are expensive and come with side effects. In some cases, they caused cancer to grow out of control, or they can inspire T cells to indiscriminately attack healthy cells.
Take the brakes off that the cancer has put in place, and it goes after the cancer, well, that means it might go after something else as well.
UCSD doctors are creating genetic roadmaps of different cancers to see how they respond to immunotherapy drugs. This may allow the creation of targeted drugs for specific cancers. Kevin Enix, VOA News.
Conclusions. This retrospective multicenter study showed that ribavirin as monotherapy may be effective in the treatment of chronic HEB infections. A 3-month course seemed to be an appropriate duration of therapy for most patients. Thank you very much.